In this video, we're going to examine a particularly critical aspect of the closing statement of Ben Myers during the trial of Lucy Letby. In this section, he talks about poor care at the Countess of Chester Hospital and errors that were made on the unit. So we're going to look through the statement that Ben Myers made in court with regard to suboptimal care. And then when he makes a specific assertion, we're going to examine that assertion. So it begins by saying, can I just pause at this point, ladies and gentlemen, to consider the fact that, of course, what we're dealing with in this case is a unit that's part of the National Health Service, the NHS, and the NHS has provided most of the witnesses in this case, and it sets the working environment in which these events took place. And I need to mention this because it's important I make it plain that in no way is this case about the NHS in general or doctors and nurses in general. It isn't. We are looking closely and critically at the level and standard of care in the neonatal unit at the Countess of Chester Hospital, amongst various issues, and the doctors and nurses at the unit, or some of them. So this is an interesting beginning where he is essentially fighting against something that Amanda Knox discussed in her podcast about the extent to which the NHS is a revered institution, and criticising the NHS is almost verboten. So he's trying to say, look, we're not talking about the NHS. I know that all the jury, I know you all love the NHS, I know you've been brought up to believe in the NHS, etc., but we're looking at the specific conditions in this hospital. And ladies and gentlemen, specifically, we are looking at that unit over a 12-month period when it did face unusual and increased demands in the care it had to provide. The trial is not about the NHS in general, and it's not about doctors and nurses in general. Although we are critical of care at the Countess of Chester neonatal unit, and we say we are entitled to be if the evidence supports this, and we say it most definitely does, there has been a concerted effort almost along the lines of how dare the defence criticise doctors, nurses and the unit, how very dare we, almost a sense of outrage, we should have done such a thing. We all feel strongly about the NHS and we are protective of it, and we're all affected by it. We'll either work in it or have family who work in it or family and friends who are in it because of the care they receive. It's close to all of us. But that doesn't mean we shut our minds to the possibility of things going wrong or mistakes being made or suboptimal care. So again, it's just a further reiteration of the theme that I just mentioned previously. So we're going to go into some of these specific comments here. Actually, at the beginning of this case, you may remember the prosecution acknowledged suboptimal care where baby D and baby H were concerned, although they've not said about baby H and suboptimal care since. They did acknowledge that at the beginning. They say there's been no medical evidence of shortcomings. We say they're wrong. There's been plenty of evidence, and we'll look at that. When we've gone through this indictment, there is evidence of suboptimal care, and I'm going to summarise, in fact, some of it now, so you follow one of the areas we'll be looking at, and so you can see why we say these things. So firstly, baby A and the delay in fluids, 4 hours, a newborn, that's suboptimal. So we'll just have a look at this claim first of all. So look at the report. This is just a preliminary report. Of course, it goes into much detail in the full report of the panel who have had access to all the medical notes, and indeed more notes than were available at the time of the court case. So you notice here, the next day at 1600 hours, the intravenous peripheral line tissued and IV fluids were stopped. An umbilical venous catheter was inserted but replaced for malposition. A long peripheral line was inserted at about 1900 hours. Fluids were reinfused at about 2000 hours. So it's this 4-hour delay between 1600 hours and 2000 hours that were mentioned in court. I'll say additionally that on the day of collapse, child A had 2 central catheters that were left without infusion for up to 4 hours, which predisposed to thrombosis when there is no infusion. Shortly after infusion was started in the most central line, child A collapsed. The thrombus from the catheter tip likely migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. So obviously what Ben Myers has said here is completely correct, although he didn't give the full context which these medical experts obviously can give. So Ben Myers goes on to say, we'll go through it. Dr. Bohin agreed that's not right, and the line that was placed too close to his heart by Dr. Harkness, not in the best position it was described eventually, and it wasn't moved, was it? We'll go back to the evidence of that. Can I say right now we recognise to assist you, the question isn't just is the suboptimal care, The question is, does that account, or can that account at least in part for what happened? So I know it's not a question of me standing here and saying this is all suboptimal, therefore the defendant's not guilty. You have to look at it in context and say, even if it was, can that explain it? That's the important thing with it. But just so it's clear, given the way that we were dealt with last week on this topic, I'm just reassuring you at this point, and maybe you need no reassurance, but there is plenty of suboptimal care knocking around in the unit on these charges. So everything that he said there, it's acknowledged in court. It's gone into in far more depth in these preliminary reports, in the full reports. There will be even more depth. That is all not contentious, not contested, just simply correct. So that's child A. Child D, and the failure to give her or her mum antibiotics when it was recognised that should have been done. Now, I think you all know about this, but I'll just show this very briefly. So here you have the panel reflecting that the mother should have been given antenatal antibiotics for prolonged premature rupture of membranes in a preterm infant. NICU admission, blood gas and CPAP were delayed for 3 to 4 hours, and chest x-ray was delayed for 6 hours, which subjected the infant to unnecessary acidosis, high CO2 and delay of antibiotic treatment. Indeed, the delay in intrapartum antibiotics was central to the collapse and very avoidable death of child D. So then he talks about child E. We say the failure to intubate or give blood transfusions in time. And then he says something that I don't think he should have said. He says, some of these are more contentious than others. Now, I think it's terrible to say that because you don't see Johnson saying, well, actually, I'm just standing here spouting a load of shit. But, I've got to do that. It's my job. So obviously, a lot of what I'm saying is contentious. No, he makes it all sound like what he's saying is self-evident. That there shouldn't be that kind of statement made. That you should be strongly emphasising that this is all legitimate, not saying some of this is more contentious than. I think that's a terrible thing to say personally. However, we'll look at child E. So in the case of child E, you see here that emergency transfusion with group O negative blood should have been immediately given earlier during resuscitation. Since 20% blood loss causes shock and child E lost much more, this was fatal. Indeed, everyone that looks at this case, other than Evans and Bohin, know that this was just a sad, probably again avoidable death due to loss of blood, due to a gastrointestinal bleed. It's only the prosecution that claims otherwise. I don't think any other doctor in the world looking at this case would conclude anything else. And as is noted here, emergency blood transfusion should have been given much earlier. So what Ben Myers was saying was completely correct. As I mentioned, I would be critical of his kind of conciliatory statement that he made, particularly making at this point where child E should be an open goal win for the defence. Shouldn't even be in the court case. Obviously, many of these cases shouldn't. Obviously, I believe none of them should be, but many of them are just so blindingly obvious that it's not malignant in any way. This is one where it just shouldn't be in court. There's no prospect this should be in a court case, and there's a standalone case. It would just be completely laughable. The fact that they managed to lose on this case is a big failure by the defence. It has to be viewed as a failure because literally any medic in the world that looks at this case will say, well, yeah, obviously there was a failure to give a blood transfusion and the infant bled to death due to a gastrointestinal bleed. And yet somehow Lucy Letby is in prison because this infant, even if she won every other case, she'd still be in prison because they lost on child E. So then he moves on to child H. There's a list there and we're going to come to it, but the standout one when we look at this case is the failure to place the second chest drain in the correct position or to secure it properly, and the failure to give surfactant when it should have been given. So this is a case for which Lucy Letby wasn't found guilty. So that is of course of relevance, but let's have a look at what was stated by the panel in relation to child H. So child H deteriorated and a chest tube was inserted to drain the pneumothorax, but a lateral chest x-ray was not performed to check its position. Its malposition led to incomplete evacuation and reaccumulation of the tension pneumothorax. And then a second chest tube was inserted, but it was not done until 2 hours after a check chest x-ray. So again, what Ben Myers was saying here was completely correct. Finally, child H's deteriorations were due to medical mismanagement of the tension pneumothorax, as stated previously. So then it's also stated here that one prosecution expert witness recognised that care of the pneumothorax was suboptimal. So you can bet your bottom dollar that this isn't Evans, and of course it wasn't. There's this discussion here that the butterfly needle left inside the baby's chest might have punctured lung tissue and contributed to the ongoing pneumothorax. Mr. Myers asked, leaving a butterfly needle in situ is suboptimal practice, isn't it? Dr. Bowen replied, yes, because it's hazardous. So the next issue cited by Ben Myers in court is highlighted here. It's child J and poor management of the stomas. So just to mention here, child J had laparotomy with small bowel resection and stoma formation of functioning ileostomy and mucous fistula for malrotation, volvulus and necrotic bowel with perforation and adhesions. She developed stomal excoriation and formation of a mucocutaneous fistula. Now, I'm not even going to attempt to guess what any of that means. Obviously, I'm not an expert on this at all. I just mentioned that obviously Lucy's not found guilty on child J. It's not one of the key cases in the court case, really, and this was essentially misdiagnosis, poor treatment. Again, it's a case that really shouldn't be in court, and it's one that Lucy won't have to ever defend in the Court of Appeal. Now, for some reason, the next statement he made is redacted. We can only imagine why that is, but given the number of people that were granted anonymity for no reason in this case, it could be for any number of reasons related to any of them, or who knows. But there's no point speculating about it, we don't know. So the next thing is child N. Child N and the failure to have factor 8 ready. Remember factor 8? It was what he was deficient in. We heard about this from Professor Kinsey. That's probably a couple of days down the line. So let's have a look at this issue in relation to child N. So we'll look at this infant in more depth. This was an infant suffering with intrauterine growth restriction delivered by emergency caesarean section. This child had mild respiratory distress syndrome and then reduced factor 8, 3%, and raised coagulation time. So you can see, because of the reduced factor 8, there was a need to provide this externally. This infant desaturated, looked dusky, was unsettled. There were issues with intubation and mottling. Chest x-ray showed right patchy consolidation consistent with infection and edema. Intravenous factor 8 was given eventually. And intubation was attempted 5 times. There are multiple errors in relation to this infant and multiple problems. I think actually this factor 8 issue is not necessarily the most important and wouldn't necessarily be viewed as the most important by the panel, but it was something that is present, and I'll go over what happened in court. Before I do that, I just mention that this is the case where Dr. Bowen makes this ridiculous comment about, I've read this second-hand account from the parents that the infant was crying for 30 minutes, so therefore it had to be deliberate harm. And they just mentioned the subsequent episode of desaturation was due to bleeding, likely spontaneously from haemophilia or routine cares, and exacerbated by repeated traumatic intubation attempts. So just very basic errors in care, errors in management here were important in the sad collapse of this infant, although this is not a case, as I mentioned. Did I mention this infant didn't die, but it's not a fatal collapse, but obviously it would have been traumatic for those the parents of the infant. So there's a discussion here about in court between Myers and Lucy regarding child N, and she recognises that factor 8 was required, as is stated by the panel. And Lucy says here, not sure, I only know what's on handover sheet as doctor, etc., all in with him doing head scan, etc. This is something she'd noted down at the time. She did not know what factor 8 referred to. The response, lad with haemophilia when worked community with Leighton on placement. And then there's a consensus that factor 8 or factor 9 needed to be given. And then there's further discussion about how there's a complex condition and there's problems for this infant. And then there's some further discussion here of a transport team from Alderhay was called out to assist and bring factor 8 as an emergency because it was recognised on the unit, as is recognised in the notes here from the expert panel, that factor 8 was necessary, otherwise this infant faced serious problems. This child did pass away because baptism was offered to the parents at some point. Oh no, maybe not. So I'm going slightly mixed up with this infant, but I think this was one where the infant looked in serious trouble and was collapsing and then recovered. Sorry, yes, that's correct. I just got confused because there was discussion of baptism. It seems a little premature, but this infant just collapsed. When I say just collapsed, I don't mean to be disrespectful, but this infant didn't pass away. And then so here is the kind of key point where it's discussed here. There was no factor 8 left on the unit, so son was brought over from Alder Hey. Obviously, that's not ideal because it had to be transported a significant distance, which is why there's this involvement of the transport team. There's a comment here that child N was the focus of the whole unit at that point, and there was concern that they couldn't get an airway in this infant. I'm sure all these incidents were horrible for those that dealt with them. And then Professor Sally Kinsey gave evidence on this, and that factor 8 is important when it was required, not on a regular basis. Her evidence isn't particularly critical, but Ben Myers is just citing it because he's citing, look, one of the prosecution experts said that she needed factor 8, and you've all heard the court state. It was stated in court it had to be shipped in from many miles away, and that's a basic fundamental error, essentially. So then we'll move on to child O. Mistakes with ventilation. So I think this is an error in the court reporting. It would be the most likely explanation because this really refers to child P. So child P, mistakes with ventilation that caused or appeared to cause a pneumothorax, and then getting the doses of adrenaline wrong pretty fundamentally during resuscitation. And again, he says some of these are clear or some of these are more contentious. I don't know why he's saying that. I think that's a dreadful thing to say. I can't understand why on earth you would say that. In fact, everything he's saying is correct, and then on top of that, there's a lot more medical mismanagement and errors that the court never heard about. So there's no need for him to say these are contentious. That is not helping Lucy. But this is child P, not child O, because child O had subcapsular hematoma and child P had a pneumothorax. So we'll look at what the panel said regarding child P. So for child P, we have a chest x-ray showing a moderately large right pneumothorax. An hour later, this infant developed desaturation and a low heart rate. I'll read this whole thing. The initial gaseous distension of the abdomen was caused by CPAP and not by injection of air into the nasogastric tube. It is unclear whether the nasogastric tube was open to drainage. Child P's care after the collapse on the 24th of June was mismanaged, and there were unacceptable delays in recognition and treatment of the pneumothorax. So essentially this is a misdiagnosis. Delay in treatment of the pneumothorax led to persistent metabolic acidosis because of persistent poor circulation and gas exchange caused by the pneumothorax. It is unclear whether the pneumothorax preceded or followed the resuscitation. Pneumothorax can occur in preterm infants with mild respiratory distress syndrome, especially with CPAP or other respiratory support, or even without any lung disease or respiratory support. The medical records do not show that a cold light test was performed. He was treated with high pressure ventilation and adrenaline despite having no lung disease and requiring only 26% oxygen. Both are harmful because high ventilation pressures impede venous return to the heart, resulting in worsening circulatory failure, and adrenaline punishes the heart by overworking it unnecessarily. There were no signs of embolism at final collapse. So you can see the catalogue of errors and catalogue of mismanagement, and the most fundamental error that can occur in medicine of misdiagnosis that occurred with this infant. This infant died from pneumothorax that was suboptimally managed, and of course there's no evidence of any air injection. So while we're on the topic, we'll also look at child O. So this is one that was not mentioned in this particular section by Ben Myers. He will be discussing that later in his statement. But I just wanted to go over child O because, of course, child P was one of 3 triplets. The second of these triplets was child O. And child O collapsed because of subcapsular hematoma. So there was a misdiagnosis here because they failed to recognise the subcapsular liver hematoma in time. Then they made big mistakes with ventilation. Again, very similar mistakes with both of these triplets, child O and child P, where they used high pressure ventilation and they didn't need to use high pressure ventilation. In fact, that made a bad situation worse. Then, of course, there's this blind abdominal insertion of a needle during resuscitation that seems to have penetrated the right lobe of the liver, causing laceration and bleeding. Blunt direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in a liver protected by the lower chest wall. And ultimately, this infant died from a subcapsular liver hematoma that was not recognised, caused by traumatic delivery that was mismanaged, resulting in hemorrhage into the peritoneal cavity that was caused by medical errors and profound shock, none of which was actually recognised. So next infant that the defence discusses here, Ben Myers, is child C. We say the failure to react to the dark bile aspirates for 24 hours is significant, although despite most of the nurses agreeing what a red flag that would be, nobody seemed ready, particularly amongst the experts, to accept that. They challenged there was anything significantly wrong. So we'll take a look at child C and the situation around this infant. What I will say is that there were multiple chronic problems with child C, and what happened in court in relation to child C was an absolute debacle. So you can see here from the panel, over the next 3 days, child C showed multiple clinical signs of intermittent bowel obstruction, no bowel opening from birth, dark bilious aspirates, bilious vomit, intermittent stomach and small bowel distension, recurrent crying. No bowel movements and dark bowel aspirates and vomiting are clear indication for urgent surgical opinion. This did not occur. Instead, despite feeds being contraindicated, he was given a 0.5 milliliter nasogastric feed. He collapsed with a major apnea 15 minutes later. So this is not only medical mismanagement, but also poor diagnosis, misdiagnosis, failure of diagnosis. And as I'll emphasize again, that is the most critical failure you can have in medicine, because if you don't know what you're dealing with, then your chances of dealing with it successfully are slim. It's not impossible, and sometimes babies will self-correct. I mean, our organs are incredible at keeping us alive, but if our organs are failing, then you've got serious problems. And if you don't recognise these problems, obviously, particularly in these vulnerable infants that are very young, very small, very premature in many cases, they have these serious problems. Diagnosis is critical. If you don't diagnose correctly, then unfortunately, the infant is walking a tightrope, and the infant probably won't survive. And so many of these cases come down to misdiagnosis. So here they go on to say, child C did not respond adequately to prolonged resuscitation because of inadequate resuscitation for 20 minutes following an acute episode of apnea. Recovering respiratory distress syndrome and severe growth restriction with myocardial ischemia would have added further to the likelihood of a poor response to resuscitation. The apneic attack was likely precipitated by severe pain due to a further episode of acute small bowel obstruction. So in addition to the failure to recognise the symptoms and misdiagnosis, they also made multiple medical errors for this infant. So next section, just take a little while to read out because there's a couple of paragraphs here. Child Q was moved to a tertiary unit after 3 bilious aspirates because that was the right thing to do on the child Q count, but you see it all changes. With child C, it doesn't work for the prosecution to say that, so they're experts backing them up. And we'll come to the experts. We're very keen to point out that 24 hours of dark bile doesn't trigger the same effect. That's why the evidence is for you, ladies and gentlemen. Much of this is linked, we say, to the fact that there were babies here who were not in the right place for their needs, and that is all on top of the medical challenges created by the condition of these babies in the first place. So we'll just assess what Ben Myers has said here. So just establish here firstly that child Q's gases were unsatisfactory and it was suspected they had necrotizing enterocolitis. He was transferred to Older Hay, this tertiary unit, where he quickly stabilised and his breathing tube was removed. So that was obviously the right course of treatment for child Q. And what Ben Myers is saying is that the prosecution refuses to accept that similar transfers should have occurred with other infants. And of course here in the panel report, it is noted that some high-risk infants who should have been born and cared for at high-level institutions were born and cared for in the Countess of Chester Hospital because of a shortage of beds at high-level facilities where they should have been admitted. So we know there are multiple infants in this court case who shouldn't have been on this unit, and they weren't even up to dealing with level 2 infants. That's very clear. So for them to be dealing with level 3 infants on what should be at best a level 1 unit is obviously potentially calamitous, and that's why they had so many problems. And there are other instances of Lucy, for example, fighting to get infants transferred to tertiary units. Now, something that is discussed in my book and something that has been raised on other channels I know is this idea that maybe they were financially incentivized to keep infants on this unit rather than transferring them out. Now, it's impossible to prove this, and I have no idea whether or not that's the case, but what is absolutely clear is that there were infants at this hospital who shouldn't have been at this hospital. So what Ben Myers has said here is absolutely correct. So the final paragraph for Ben Myers in this passage goes as follows. It is easy, isn't it, to lose sight of how clinically fragile babies like baby G or baby I were, and how prone they were to serious problems, irrespective of what is alleged against Miss Letby, and how often they were being cared for, we say, by staff who were not always adequately qualified to give them the support that they needed. And of course, if that happens in one place, that can put pressures on the unit or on staff elsewhere. So firstly, this final sentence cannot be contested. It's undeniable. Secondly, he makes this comment about staff being underqualified, they didn't have adequate support on the unit and so forth. We know this staff was understaffed, we know it was underskilled, we know they had insufficient experience, that's why it was downgraded, it has never been returned to its level 2 status. The final statement he makes is in relation to child G and child I being clinically fragile, so let's examine those two infants. So child G was born at 23 weeks, extremely premature, 500 grams birth weight, so half the size of a 1 kilogram bag of sugar. Female infant born in the toilet at Arrow Park Hospital after premature rupture of membranes with suspected chorioamnionitis. So obviously a lot of chronic conditions and chronic issues immediately. Resuscitated at birth and treated for severe membrane hyaline disease, bilateral pulmonary interstitial emphysema, hyperglycemia, anemia, and thrombocytopenia. She had patent ductus arteriosus and mild bilateral dilation of the cerebral ventricles. So a lot of problems. I think anyone can reasonably say this was a child with chronic issues. Just simply the fact the child's born at 23 weeks is enough. You don't really need to read beyond that. And then child I was born at 27 weeks, so only slightly older than child G, just under the size of a bag of sugar, 970 grams, female infant with intrauterine growth restriction, again born after premature rupture of membranes at Liverpool Women's Hospital, treated for mild respiratory distress syndrome with respiratory support and antibiotics for sepsis beginning on the first day of life, and so on. And so it goes on. No one can possibly disagree with what Ben Myers has said with regard to this infant. And then on top of that, you have multiple failings from the Countess of Chester. So I will add some further picture for these 14 points where I can. For some of them, I definitely won't be able to. But the first two, medical histories were incomplete and failure to consider the obstetric history. So firstly, I have written more about the medical histories and medical notes in my book because I've received more information about this. Let's just say that what is stated here is an understatement. With regard to failure to consider the obstetric history, you've heard about this extensively from Martin Pittman on this channel. The defence certainly, or the expert panel that are effectively acting in Lucy's defence, but really they're just doing a proper medical investigation of this hospital that should have happened a long time ago. They're obviously trying to get hold of the obstetric notes. I believe... Well, I don't have the full picture with regard to this, but I know that significant effort has been made and they already know more than Dr. Evans did because he made no effort to get the obstetric notes. disregard for surveillance warnings about infectious bacterial colonization. So this is a major problem. We know about the sanitary conditions on the unit. I've got multiple microbiologists in my book discussing this, discussing the problems. We know how this was then transferred into the infants, into observable symptoms, observable clinical signs, and it's hardly surprising that some of these infants indeed collapsed as a consequence. Misdiagnosis of diseases, of course, this is a major problem. I mean, this in a sense, this should be top of the list. But I know it's hard to say because medical histories being incomplete is pretty serious as well. But misdiagnosis is pretty much the most fundamental medical error you can ever make because, as I mentioned, as soon as you've misdiagnosed something, you're then going to mistreat it. At best, that can have no impact on the condition, and potentially it can make things worse. And we see that with the ventilation, for example. They ventilated at high pressure when they shouldn't have been ventilating at high pressure, and that just made a bad situation worse. Next one's caring for patients that were beyond their designated level of care. So we know that's the case. We've established that in the video. There is no doubt that there were multiple infants in this court case that shouldn't have been at the Countess of Chester, that shouldn't have been born at the Countess of Chester, that should have been transferred out of the Countess of Chester. And most infants that were transferred recovered. That's not true of every infant because Child K, for example, sadly passed away at a different hospital. But had these infants been dealt with differently, I would say appropriately, then their outcomes would almost certainly have been very different. Next one is unsafe delays in diagnosis and treatment of acutely ill patients. So this is very much tied to the misdiagnosis of diseases. So they either made mistakes in diagnosis or it took them a long time to recognise what was happening, and then consequently they didn't respond in time, and then consequently what is described here as acutely ill patients. These infants are very vulnerable. They're all on the verge of collapse at any given moment. They only survive because they're in a neonatal unit. And if you make mistakes, and if you don't if you don't diagnose quickly, then it's a major problem. And this was a very obvious failure on the unit. It's becoming more obvious the more that I understand about these cases. And because of this delay in diagnosis, they weren't able to give the treatment in time. That's when they actually diagnosed correctly, of course. And that's a major problem. Then poor skills at resuscitation and intubation. So we know how many poor intubations there were on this unit. We know how many mistakes they made with resuscitation. Again, there is considerably more detail regarding this in my book, with new information about the resuscitations and intubations. Poor supervision of junior doctors in procedures such as intubation. So it's difficult for me to comment on this because I don't know too much about it. But it's clear that they made major mistakes with intubation, and it's easy to see how a lack of supervision of what were junior doctors, this is happening multiple times. There are multiple cases with intubation after intubation after intubation, failed intubations causing clinical signs and trauma and physical damage in the infants, and yet they're still trying to intubate. So it's easy to believe that there was poor supervision. Poor skills in basic medical procedures like insertion of chest tubes. So I don't think this is open to debate. We've seen the problems on the unit. We've seen how poorly some of these basic medical procedures are conducted. Lack of understanding about respiratory physiology and basics of mechanical ventilation. So all I can say with regard to this is we've seen how they've misused ventilation and that has caused problems on the unit. I think it's difficult for me to expand on that any further. It does seem from the efforts to intubate and resuscitation that there were misunderstandings regarding respiratory physiology as is suggested here, but I think that's a bit above my pay grade to comment on. Poor management of common neonatal conditions such as hypoglycemia. Again, we're going to go on to this actually later in the video. They made serious mistakes with regard to child F, for example. Lack of knowledge about commonly used equipment in the neonatal unit, e.g. Neopuff, capnograph. Again, this is very easy to believe. It's difficult for me to comment on this. I'm not experienced with neonatal care, so I can't really criticise people that are doing it professionally, but the panel obviously do feel able to do so. Failure to protect at-risk patients, e.g. haemophilia from trauma during intubation. Again, we know how bad the intubations were in this case. I think this is pretty much impossible to contest. And finally, lack of teamwork and trust between the health professions. Again, I can't really expand on this, but we know that there were kind of fissures on this unit between the clinical team, the nursing team, and eventually the executive team. So it's not difficult to believe that there was a lack of teamwork or trust on this unit. And then there's 11 further issues here. Inadequate numbers of appropriately trained personnel. We know this is the case. We know they were underskilled. We know they were understaffed. And that very much feeds into the second one, lack of training for assigned nursing roles. So that number one is a consequence of number two, essentially. And then number three, inadequate staffing. Again, we know they were understaffed. We know they had to get part-time staff in. We know they didn't have sufficiently trained personnel, and so on and so forth. The fourth is a consequence of this, which is work overload. So Lucy is in prison because of this, because Lucy took on extra shifts, and then she was on the unit more often than others, and then the suspicion began, and then they used the crappy commonality shift chart that has no value whatsoever. So because of the work overload, Lucy Letby sitting in prison. And then there's poor plumbing and drainage, resulting in need for intensive cleaning. This was a potential factor in Stenotrophes monas multifila, colonisation and infection. So we know that's the case. Of course, we know about the plumbing here. We know about the drainage. We know about the sanitary conditions. We know about the need for intensive cleaning. We know about the Stenotrophes monas. We know about other conditions circulating on the unit. Pseudomonas, for example, is enterovirus mentioned. We know this is true. Poor environmental temperature control in facility. So this has been explained to me. I wouldn't wish to comment on this too much because it's not an area where I would have any particular knowledge and certainly no experience. Difficulty in finding a doctor when need arose. Well, this has been pretty well established by the lack of ward rounds, by the fact they're covering other units, by the fact that one of the doctors thought he was a TV star. Congestion at medication cabinet and preparation trolley. I can't comment on this. I'm sure this comes from the medical notes and from various things they've been able to glean from the information that they've studied. I can't comment on it. Lack of appropriate facilities for sterile preparation, e.g. IV drugs prepared in corridor. That's obviously very serious. I think it's undeniable that IV drugs were prepared in the corridor. This was discussed in court. That's not open to debate. The panel are very well placed, of course, to state that this is inappropriate. Some high-risk infants who should have been born and cared for at higher level institutions were born and cared for in the Countess of Chester Hospital because of a shortage of beds at high level facilities where they should have been admitted. So again, we've discussed this already. I'm not going to go over it again. We know this is true. We know infants should have been cared for at high-level institutions. We know they should have bitten the bullet and transferred some of these infants. Some of them shouldn't have been born at the Countess of Chester. We know there was a shortage of beds at high-level facilities. We know this was cited. We know these infants were transferred around way more than they should have been, and that leads into number 11. There were delays in transfer of sick infants to high-level facilities when the need arose. So these infants were transferred too much as it was, but even when they were transferred, there were delays in these very important transfers, which of course are extremely critical in these very sick infants. So with regard to the assertions made by Ben Myers in court, there was a 4-hour delay in fluids for child A. There was a failure to react to the dark bile aspirates for child C. There was a failure to give the mother antibiotics for child D. There was the failure to intubate or give blood transfusions for child E. Child G was particularly clinically fragile. There was a failure with the second chest drain for child H. Child I was also particularly clinically fragile. There was poor management of the stomas for child J. There was a failure to have factor 8 ready for child N. There were mistakes with ventilation that caused pneumothorax for child P. Child Q is absolutely indicative of tertiary transfer failures across the unit, across multiple infants. It's true that infants were not in the right place for their needs, and it's true that staff were not adequately qualified. So that leaves us with child B, child F, child K, child M, and child O that Ben Myers hasn't commented on. I should say there's many other failures for the infants that he has commented on, but I just wanted to go over child B, child F, child K, child M, and child O in this video. So firstly, in the case of child B, as it's noted here, the sibling child A suffered similar collapse and died 1 day after birth, and post-mortem showed a recent non-occluding thrombus in the liver, indicating a recent thrombotic event. Consequently, child B was at high risk for thrombosis, so this should have been recognised. It's yet another diagnostic issue. Child B was resuscitated and intubated with size 2.5 endotracheal tubes after 3 attempts, so it's yet another poor intubation. Vocal cords were red, swollen and inflamed. There was a large air leak, so the endotracheal tube was removed and continuous positive airway pressure was applied. So there are some of the problems with child B. Child B collapsed from thrombotic emboli originating from a central intravenous catheter, which was potentially aggravated by maternal antiphospholipid syndrome. In the case of child F, at 1000 hours on one day that the child was being cared for, I believe this is on the 5th of, or is it on the, yes, on the 5th of August. Child F's long IV line, intravenous line, was noticed to have tissued with extensive swelling and induration of the right groin, thigh and leg. Intravenous fluid was stopped from 1000 to 1200 hours where a new long line was inserted. Obviously, yet another medical blunder. The hypoglycemia for child F started with sepsis and was prolonged because the IV infiltrated for several hours. When hypoglycemia persisted despite 10% dextrose infusion, a higher glucose infusion should have been given earlier. Repeat boluses of 10% dextrose worsen hypoglycemia because they cause surges of blood sugar, which trigger surges of insulin secretion, resulting in a yo-yo pattern of sharp rises and falls in insulin and blood sugar. So this is mismanagement of the infant. In the case of child K, we could just simply say the infant died 3 days later in another hospital and there's literally zero evidence. But let's have a look at the actual failures with child K as well. So child K required a size 2.5 endotracheal tube. Instead, she was traumatically intubated with a size 2 endotracheal tube with a resulting 94% air leak. As a result, ventilation was ineffective because 94% of the air was leaking out and only 6% was entering the lung. Now, in a recent video, I went over what Dr. Ravi Jairam said in court with regard to child K, and he tried to defend this and say that it doesn't matter what size endotracheal tube you use. Now, given that this resulted in a 94% air leak, I think we can put that to bed immediately. But as I said at the time, why are there different size tubes if it doesn't matter what size you use? And so for child K, the clinical deterioration was caused by the use of an undersized endotracheal tube. The initial intubation was traumatic and poorly supervised, and the consultant did not understand the basics of resuscitation, air leak, mechanical ventilation, and how equipment that was commonly used is a correct way of describing it as well, commonly used in the unit worked, e.g. neopuff and capnograph. So then I'll move on to child M. 2 doses of adrenaline were given before the airway of this infant was secured. Child M had possible signs of sepsis from birth, including jaundice, requiring phototherapy and hypoglycemia, and was treated with antibiotics. The next day he clinically deteriorated for 4 hours prior to collapse, with abdominal distension, increased work of breathing, raised temperature and bile-stained nasogastric aspirates, and which were of concern to the nurse and registrar. The acute episode of desaturation and bradycardia was likely triggered by apnea from sepsis, abdominal distension with ileus, and prematurity. It could also be due to the cardiac eustachian valve, which can cause episodes of desaturation and bradycardia due to intermittent right to left shunting of blood through the foramen overlay. So this is all medical mismanagement errors all over again in this infant. The resuscitation was chaotic, with 2 doses of adrenaline given before the OA was secured, so yet more mistakes. Now we're going to move on to child O. So I've discussed this already. I'm not going to go over it all over again. We know the multiple errors with this infant. I discussed them earlier in the video. There's errors with diagnosis, there's errors with ventilation, there's errors with giving a blind treatment, there's errors with needling. Almost anything that could have gone wrong with this infant did indeed go wrong. So, as mentioned here, child O died from a subcapsular liver hematoma that wasn't diagnosed, caused by traumatic delivery that was avoidable, resulting in hemorrhage into the peritoneal cavity that was caused by errors on the unit and profound shock, none of which was actually recognised. So I've summarised this here by saying misdiagnosis, blind needle error, ventilation exacerbated hematoma. So finally, I just want to mention as well, because Ben Myers didn't mention this, that there was a diagnosis failing for child I, and they did not treat this infant with appropriate antibiotics, and child I was likely preventable death as well. So if you sum all that up and add in what I've just gone over for the infants that weren't mentioned, you can see across all of these infants there are multiple errors, and I've been informed of this. This is discussed in more depth in my book. There's new information in there regarding some of these infants. So a lot of this is avoidable. Certainly, there are major errors and major poor care across these infants. That is undeniable. And everything that Ben Myers said is true. but it really only scratches the surface of the problems. And even what is written here only scratches the surface of the problems. It is much more serious because I've been very reliably informed that there are multiple errors for every infant, virtually. That it's not just that they made one mistake for each infant, it's just one error after another that just magnifies the problems. And then, of course, we also have these 14 issues that I already mentioned and these 11 issues that I already mentioned. So there are fundamental problems, fundamental lack of understanding, fundamental misdiagnoses and lack of diagnoses, medical errors, poor treatment of infants that were very vulnerable, and they're being treated on a unit where they shouldn't be resident in the first place, that has very poor sanitary conditions. So we know what caused the death and collapse of these infants. There's a particularly challenging acuity of infants in a short time frame. Many are critically ill in what is a relatively brief period of time. There's an extremely high percentage of multiple births, which creates a disproportionate strain on resources, capacity, and I would say skills and knowledge on the unit. They're understaffed. There are too few staff to meet the needs of these highly fragile infants, and I think there were certainly cot shortages across the Northwest region as a whole. They were underskilled. There was inadequate experience and training to care for this very difficult acuity of infants that they were forced to deal with. As has been extremely well established, there were unbelievably poor sanitary conditions on this unit. There's a high infection risk due to an unsanitary environment, and comfortably the majority of infants on the indictment suffered some form of infection. Many of them suffered more than one type of infection. This was a crumbling neonatal unit that was set to be demolished. The physical environment was unsafe, it's outdated, it was deteriorating, and they knew that it was unsatisfactory. It was unsatisfactory for any infants, essentially, but for the infants that they had to deal with, inevitably, this caused major problems. These were chronically ill infants, and there is no doubt that the state of these infants was dramatically misrepresented in court. The severity of illness was either downplayed or the court and jury didn't hear of it at all. There were then multiple medical errors in treatment, medication, monitoring, and basic procedures, and there were numerous misdiagnoses. The failure to correct conditions, fundamental to the treatment that had to be given. And then in some cases, diagnoses were delayed to the point where they couldn't respond satisfactorily. And then this was exacerbated by poor medical management, inappropriate or delayed care, and treatment decisions. And all these things together add up to what was a picture of general dysfunction at the hospital, with a breakdown of systems, care, leadership, oversight, communication, and accountability. Almost inevitably, for these vulnerable infants, there were poor outcomes which resulted in collapse or death. And then finally, I will add that some of these infants could or would have collapsed or died at a competent hospital. So you can see the dangers that they faced at this hospital, where there was this perfect storm of all these factors that ultimately caused the collapses and deaths of the infants on this unit. And Ben Myers was absolutely correct to cite poor care, and everything that he said in court was completely accurate.